Thank you. Thanks so much for that kind introduction. And I'm going to shift gears from what I talked about earlier, which was really where we are today with protons. And now I'm going to shift to the future, where I think we're going. I think, you know, when I talk about FLASH in a nutshell, you know, if I came, you guys all know, when we treat a patient with conventional radiation, they're usually getting typical radiation over 5, 6, 7 weeks, and they're coming in every day, and they have certain toxicities, and it's a lot to come back and forth and get treatment all the time. Well, what if I told you we were working on a new modality that said, you know what, you're diagnosed with cancer, we're going to treat you, it's going to take us less than 1 second, and you're done, and you have less side effects than anybody before you. That's game-changing, right? That changes cancer. That changes a cancer experience. It doesn't just change radiation oncology, that changes all of oncology. And it has huge implications. But that's what we're working on. And that's what we're working on with FLASH. And I'm going to go a little bit through where the data is and where we're going with that so far. So what is FLASH? So FLASH is any ionizing radiation, whether it be photons, protons, electrons, carbon, but give it what we call ultra-high dose rates. When I say ultra-high dose rates, it's 40 gray in less than 1 second. It's an entire treatment course. It can be less than 1 second. And it has to be less than a second. We'll get into that. And there's a number of preclinical studies out there that have shown that FLASH can be less toxic, but just as effective as conventional radiation treating tumors. Now, this wouldn't be a discussion at all if it wasn't as effective at treating tumors or protected tumors in some way. Then we wouldn't be having this discussion today. And why is it important? Well, it could potentially be a disruptor in oncology. It could really revolutionize radiation down the road. It certainly changes the experience and number of treatments and reduces patients back and forth, treating a much broader number of patients. And there's a lot of evidence out there. Actually, and the first evidence that was out there, which I'm not going to get into today, was in electrons. Turns out it's much easier to give very, very high dose rates with electron machines. And there was some great work that's gone on in Switzerland that really identified this work. And then, you know, when this came out, we said, you know, why don't we apply this to protons? Because electrons have its own set of challenges. Electrons, although you can give very high dose rates, you can only treat superficial tumors on the skin. You can't treat deep-seated tumors. They are working on something called VHEs, very high energy electron machines that aren't out yet, but you kind of lose the effect because you have to treat all the way through and through. So you don't have the benefit of sparing tissue with that. So protons are in a very unique space. Now I showed this slide earlier. I bring it up for a different reason. You heard about 2 types of protons. There's a Bragg peak, which is the red line. That's what we do pencil beam scanning with that I showed you before. Then there's that spread out Bragg peak, the blue line, where we spread out over a whole area. So most of the work that's going on FLASH has been basically using the plateau region of the Bragg tree and shooting all the way through a target, all the way through an animal, all the way through somebody. So most of the data is on that. We're working on conformal FLASH, which uses the Bragg peak, and we'll get into in just a little bit. So I showed this already. Remember, this is what we do with protons. It takes 2 or 3 minutes to deliver a proton treatment itself, and I'm not going to go through the whole thing again. Well, what about treatment with FLASH? That's it. Done. Entire treatment course, potentially. That's what a FLASH would be. Now, we're initially doing it in some fractionation over a few fractions, but ultimately that's where it could get to. So why proton FLASH? Well, there are pretty big challenges of developing a machine that can treat deep-seated tumors for both photons and electrons, more so for photons than they are for electrons. And there's proposals out there, but they're probably a decade away if they become commercially viable. And protons, you can't do it with every type of accelerator. You saw that, you saw synchrotrons, there's cyclotrons, there's synchrocyclotrons. They all have different structures to them, and the structure of the beam is different. It turns out the cyclotrons, which we have with our system at our main site with IBA, can easily generate FLASH dose rates. Synchrotrons, it's actually a real challenge to do it. Synchrocyclotrons, some, not all of them. So not all machines that treat protons can treat with flash because they can't get to the flash dose rates, but cyclotrons absolutely can. I think it's been really important time and time again. This is just data down below looking at pancreatic cancers for us, also at Penn and MGH, looking at tumor control, and there's no difference in tumor control when you do standard dose rate fractionation with protons or flash fractionation. So, and we have looked at, it's been published on multiple tumor models, and there's no difference in that. And we'll get into that in a bit, because there's a lot of questions why. And what's the mechanism of this, which we're still trying to work through. So I'm going to start with some of the conclusions. That way, if people don't want to follow in the lab-based slides, they can go to sleep for a little bit. But it's good to understand where are we today? And I'm going to summarize a lot of data in one slide. So the flash effect is absolutely real. It's been demonstrated for electrons, carbon, photons, and protons. All those machines can elicit the flash effect. It shows normal tissue protection. Wherever you go, whether it's chest, whether it's brain, whether it's abdomen, whether it's pelvis, those tissues, we see bone, we see normal tissue protection. The flash shows at least similar tumor control. There's been some things that's a little better, but I would say at least similar tumor control. And stem cells, or the stem cell compartment, is somehow preserved with flash. And we'll get into why we see that. So dosimetry and physics and control of the beam is absolutely critical for the flash effect. And it turns out very small changes in the beam structure can have changes in the biology of the outcome. And I've never seen this where technology and biology are so tightly intertwined, which actually is fascinating to me. It's always been separate. When I went to physics class and biology class, when I was a resident, they were completely separate things. This is completely intertwined. And I'll give you an example. We were treating patients every day with conventional radiation in our department, no issues at all. We were doing flash at night because that's when we get the beam time, and we saw the flash effect in multiple experiments, and all of a sudden it stopped. We weren't seeing the flash effect in the same experiments, and we were trying to figure out what was going on. It turns out there was some small drift in the RF system that goes into the cyclotron that didn't make a meaningful change in the dose given to patients that we're treating today. But that small drift in the RF actually changed the biology of what we were seeing. So that comes back to the dosimetry, control of the beam, control of the system is much more critical when treating with flash than it is in what we would typically think about with a linear accelerator or cyclotron. We know also the flash effect is lost if we go too slow. So if we give a dose rate below 40 gray in less than a second, 30 gray, 20 gray, we don't see the flash effect. If we go more than a second, 1 second, 2 seconds, 3 seconds, we don't see the flash effect. We actually typically are treating around 100 gray in less than 0.2 seconds is what we do. We see the flash effect. But you go more than that, you start losing the impact. And there is a window of opportunity with flash. The first paper that came out on electrons showed it's 100% effective and all this kinds of, it isn't. What we found is if you can give too high a dose at one time, it overwhelm the flash sparing effect. And too low a dose and we don't see the effect. So there's a window of opportunity, and that window of opportunity is complicated because it's probably different for different normal tissues. And we're probably going to have to think about how we treat tumors in the future. Because right now, when I write a prescription for radiation, I write a dose, I write a fractionation, and I say the total dose that certain organs can receive, and then we look at our dose volume histograms and what are we going to do? What we'll probably have to do with flash is actually define dose rate and dose rate by normal tissue, which is very different than what we're used to thinking about now, looking at multiple normal tissues at the same time. And when I opt, and I'll get to more of that later, so that changes the way we kind of prescribe dose and think about dose in the future. And I'll come back to, I think, this has an opportunity to be a major disruptor in all of oncology. You know, when I look at a lot of what we've done over the years in research, in science, and over my career, we generally make small iterative changes. We get a little better here, we get a little better there, it builds upon itself, and over a number of years, we get better. This has a chance to change everything in a very, very short period of time if it comes to fruition as we work through this. So this is the program that we've been working on at the University of Pennsylvania, our flash radiation program. We started this, the first literature came out around 2015 or so, and the electron stuff, and we said, let's think about this and apply this at Penn and with protons, because so we could treat deep-seated tumors. We spent about a year, started in 2018, we spent a year like working on the dosimetry and defining things, ultimately defining things in cells and cellular models. And then we went into small animals and mice for a while. And we understood we had to get into understanding what is the mechanism of action? How is this working? And we'll get into that in a little bit. And then we said, you know what? This is really complicated. I didn't feel comfortable going right to humans. So we said, let's work with the vet school, the veterinary school. We have a veterinary school on campus. So we work with the veterinary school, design clinical trials for comparative oncology trials with patients' pets. So we do a lot of canine dog treatments. I like dogs. I'm not giving dogs cancer. We're helping people's pets that have cancer, and they're on our clinical trials. It turns out it actually can be very good to run in large animals like this before going to patients. So we've been testing and working in canine models, a few clinical trials already. And then our plan is next year to go into human clinical trials with this technology. So it's coming soon for us. And our program is pretty complicated. We had an initial investment in this in the department to kick this off and get it going. Then we had a large program project grant from the National Institutes of Health in the US, a $12 million grant that helps us start looking at how we do this with animals and mechanism of action. We worked with IBA, who has a sponsored research agreement with us. I had certain additional grants from philanthropy and foundations to keep us going, where we started looking at normal tissues, even outside of cancer. So we're looking in depth at things like cardiac disease, believe it or not, and using flash radiation in that area. So to give you an example, we have a lot of data out there on using SBRT for ablation of ventricular tachycardia. And that's a malignant issue in non-cancerous patients. And we have clear data that those patients can respond dramatically. We have patients in the ICU that are getting shocked multiple times a day. We treat them with SBRT, and a day later they're walking out of the hospital without getting any shocks. So it's pretty amazing. But the problem is there's a lot of thought on how this works, and I'll get into the mechanism of that first. And it was thought, oh, we're causing fibrosis by giving radiation, we're affecting the tracts. Well, fibrosis doesn't happen in 24 or 48 hours. Fibrosis takes weeks or months to happen, so it's clearly not that. But we also know fibrosis is bad for the heart. So, and we also have proven with flash that flash doses to the heart can get rid of this ventricular tachycardia and not cause fibrosis. So there's a whole benign disease area, which I'm not going to get into today, that we're also looking at. So this was the first study we did, and we did a very simple experiment looking at mice, and we looked at whole abdominal radiation. And Giannis is in my department. He's fantastic. And he did his first study looking at whole abdominal radiation. And we tried to get to the LD50, the lethal dose 50 rate of what we would see with giving conventional standard radiation fractionation versus doing proton flash. And we got to that. And you see that first slide there. You see we gave 14 gray to male mice. And you see that separation of the curve between no radiation in blue, flash radiation in green, and then red, standard dose rate radiation. And this big gap in survival. And we did the same with female mice, and you see we gave 14 gray to female mice. There was also that same gap. But if you go a higher dose to 18 gray, they all died. So that means, again, there's a window. There's a window where we can see this separation of reduced toxicity, but you can overwhelm the flash effect with too high a dose. So that's where fractionation may come in some with this down the road. And we've learned after this, it's different for every normal tissue. So that 14 gray is in the abdomen. It's different for the chest. It's different for the brain going forward. But what did we see in the abdomen? And this is a little tough to see, but if you look on the top 3 panels, that is the bowel. that we've cut up and put on H&E staining. And what it has is a thin fibrous layer at the edge of the bowel, and you've got villi, and the villi would absorb fluids, nutrition, things like that in the bowel. When we give standard radiation, that's the middle panel. And if you go all the way over to the right, the middle panel, look how thick of fibrous tissue we see in there. So there's a huge expansion of the fibrous tissue when we treat with standard radiation. And you also see those villi that were nice and organized are destroyed. And that's why we see when we treat the abdomen in patients or pelvis, we see diarrhea because we affect the villi in the bowel and those die off and they get all kinds of diarrhea and nutritional issues. That's why. But if you look down the bottom, right, that's flash radiation, which looks almost the same as what we see with those who are not radiated at all. In fact, up top, you see the difference. This is look at the average, that's the average thickness of what we see of the layer that's at the edge. And you look at the blue is no radiation. This is the graph on the side. The green is flash radiation. And you see the difference with conventional. Significant expansion of what we see there. And it affected the villus layer. Again, no difference in tumor control between flash and standard radiation. So this was a very basic experiment we did to see, is there something here? Because my team thought I was crazy again. I told my team I wanted to do this flash work. My biologist said, this can't be right. There's no way this is real. Then they did it. They said, this is a fluke. They did it again, and they did it again, and they kept seeing the flash effect. And then we went to other disease sites. So my biology team were appropriately skeptical. Now they're all in, and they're very interested in this. So flash has actually been delivered clinically, and it's actually being delivered clinically in the United States at Cincinnati in a very rudimentary technique, the shoot-through technique I told you about. So taking that flash beam and shooting that plateau region of the beam all the way through the animal or all the way through the individual, which means you're not sparing any tissue. You're going all the way through and you're completely relying on the flash effect to reduce toxicity. Now, this was a feasibility study at the University of Cincinnati. They just wanted to show you could deliver flash. And what did they deliver? They delivered 8 gray times 1 to a peripheral bone met. And they were able to do it. And they were able to do it safely. But I would argue we do that now with conventional radiation. It doesn't really move the needle at all on that, except we can do it. They've now moved to FAST-02 trial, which they're currently accruing to, and that's metastatic lesions in the chest, close to central structures, which has more risks. So that's the current trial that they are enrolling on with shoot-through flash. We are going at this a different way, that we really believe that protons offer an enormous benefit over conventional radiation with photons by using the Bragg peak. You saw that cartoon earlier where I showed how we treat spot by spot and we paint by number a tumor with no dose beyond the target. That's what we're doing with flash at Penn. We believe we should be using the Bragg peak to its fullest extent and not relying on the flash effect fully. So we are not treating with shoot-through technique. Our initial experiments were with animals. Our experiments now, or our clinical trials now, are conformal flash. So we are stopping the beam, not treating any tissues beyond the beam, and giving much lower dose in the front. We think that's going to even show a bigger flash effect because I think of our first experience as being a little dirty because we were shooting all the way through everything. Now we're not. We're actually minimizing what we're shooting through. And, shooting through on the top pounding, so you're shooting right through the heart, you're shooting through the lungs. We can avoid that and stop the beam and just put it exactly where we want it. So we've had to modify our nozzle. You saw that nozzle in the talk I gave earlier. What is this on the right? It attaches to the IBA system, and it includes a couple parameters. One, it includes all the way at the end that brass aperture is basically to conform the beam laterally. So it's a block. It's a brass block, conforms it laterally. Those slots in the middle where we can slide things in and out, spread the beam out as much as we want it spread out, depending on that target. However many centimeters is a number of slots. We put that in. Then the hedgehog, that's a 3D printed lucite type of thing that's made for that individual patient based on the planning to perfectly conform that dose of where we're depositing it to the deepest layer. So we've kind of gone backwards a little bit into what passive scattering was. We're still doing we're just still doing scanning. We're spreading this out. We're doing a single shot, but we're doing multiple shots in a short period, less than 0.2 seconds. But we couldn't do multiple layers with pencil beam scanning. So we're doing a number of layers at once all the way across the field by creating this hedgehog and spreading out the beam itself. So I was pretty passionate that I thought we couldn't go right to patients with this. I thought we had to work things out with animals, and it's been important for us. So we could work out the feasibility for disease sites and go end-to-end testing all the way through. We could work on the mechanism of action. We could define the safety before treating humans. I'll tell you, we had an episode, we were treating a dog where everything was manual at the time, and we were relying on our IBA engineer. We'd call in, hey, we're ready to give it treatment. They had to put it in the right mode. We would actually treat the mode. Well, it turned out it was put in the wrong mode. And instead of delivering flash, we gave conventional dose rate. You can imagine if it was the other way, we made a mistake on a human and treated a whole dose into a human on a mistake. So that's been optimized and automated. So we made those mistakes in animals that I don't want to make in humans. We could do end-to-end testing and again, make those mistakes like I said, which has been critical as we go through this. So I'll describe a couple of the trials we did in canine animals, dogs. The first trial we did was actually 29 dogs were randomized. They had osteosarcoma, so sarcomas of the bone in the extremities were generally large dogs that get these sporadically. So what we did, the treatment, the standard of care for treating large dogs with osteosarcoma is actually amputation. So what we did was we did a clinical trial with the vet school to actually treat these animals 5 days before amputation. So we could look at any response data on the tumor, how it responds, look at normal tissue. So we actually treated the tumor, then we treated another area of the extremity. So we could get data on bone, on blood vessels, on muscle, on nerves, and how these all responded to flash. And then we did single cell sequencing on these things. We're actually this trial is about to come out. It's just been submitted actually. But we learned a lot through this and being able to do it this way. And that's just kind of the setup with the dogs. And we did a post-operative sampling where we had marked everything out, and we were able to histologically look at all these things under the microscope and send for RNA sequencing also. And I'm going to talk about our next trial because we actually plan to go to a next trial, which I'll talk about in a minute, which is to do this with dose escalation without amputation. So next trial is not amputating the dogs, and I'll talk about that in a few minutes. So this is also in the right, this is the panel. If you look over to the right, there was very limited toxicity. These dogs tolerated this very well. We had one that had a pathologic fracture in the standard radiation arm, actually could have been related to the tumor also. And we had a bleed in one patient with the flash protons. But we definitely saw different molecular responses. This just shows a TGF-beta. So the TGF-beta is elevated significantly in standard fractionation, which is an inflammatory marker. It stimulates macrophages to come in. And on the right, you see in the flash protons, there was no stimulation at all of TGF-beta. So different inflammatory response. And what we've seen now in multiple studies, we see different inflammatory responses, and we see different immune infiltrates in the tumors themselves. Now, why is that important? If we're seeing different infiltrates of tumors by immune cells, that means different biologic pathways are being activated. That's druggable. So there's the potential for all new radiation drug combinations with flash, which is where I'm most interested, not even just the flash effect. It's the ability to combine with chemotherapeutics and biologics in new and novel ways that we can't do with conventional radiation. And we've seen this in a number of tumors, including brain tumors, going forward. So it's an area we want to continue to explore and go forward. So after we did those two trials, we got significant interest in head and neck cancer, which I'll get into in a few minutes for a variety of ways. Turns out, let me skip that. I'll tell you our current study. It's ongoing. Sorry, I'm getting ahead of myself. This is for soft tissue sarcoma. So this is the trial where I said we're going to dose escalate, but we're also going to avoid amputation. That's this trial here. We've actually enrolled 2 dogs thus far. I have another dog that's simulated. We're going to start treatment in the next week or so. And we have another one that's consulted with simulation upcoming. So I'm hoping by mid next year, June or so, We'll actually finish this trial, but the idea is to avoid amputation. We're doing soft tissue sarcomas for a reason. It turns out the osteosarcomas already have a lot of bone destruction and weakening, so many of them need amputation because it's going to fracture no matter what you do. So we're going with soft tissue sarcomas that don't have involvement in the bone, so we can show and that the treatment of that is also amputation, so we can show that we can preserve the bone by the flash effect with this. So we thought a lot about, we treated, I think, over 11,000 animals total so far. So we've done a lot of trials. And we've thought a lot about where do we want to go clinically with flash, where we have challenges today, where we see where we can have the most effect. And in thinking about that, we decided, head and neck cancer is something that's pretty morbid, but particularly when we're doing with combined modality therapy, can be a difficult thing to treat. It's easy to look at both in the skin and the oropharynx, looking at scoping people. So we knew we'd get data pretty easily. So we said, let's do some work with head and neck cancer. And we started actually in a mouse orthotopic syngeneic model where we treated them first. We then moved into canine head and neck cancer patients in a clinical trial, which we've completed, which I'll show you in a few minutes. Then with the plan of getting data to submit to the Food and Drug Administration in the United States and get approval to use this flash in human clinical trials. So where are we? When we first started looking at oral mucosa and salivary gland treatment with mice, we were delivering 16 or 18 gray to the oral cavity, oropharynx in mice. And we had stopping rules on survival. These patients, if they got such mucositis they couldn't eat and they were losing weight, they were euthanized. So we could check out which were we affecting more. And we looked at basically at survival. And again, we got to the LD50 with this dose rate. And you can see the significant difference between what happens to the mucosa and side effects in mice treated with standard radiation in red compared to green. So big gap. And this is 40% is usually what we keep seeing, this reduction in toxicity. That's a big number. There's no drug that does 40% reduction in toxicity. If you get 10%, that would be a home run in a drug. This is like a 40% difference that we're consistently seeing with these. So this is a little gross. This is the tongues of a bunch of mice. But what this looks at different days after treatment. So the no radiation is at top. And these are stained with toluidine blue, which really looks at oral mucositis post 16 gray of radiation. If you look at the standard proton dose rate, you can see within 10 days you're getting significant mucositis, and you see by the time you get to 28 days, really significant inflammation, mucositis that we're seeing these. The bottom panel is flash. And it looks much closer to no radiation at all than it does to the standard dose radiation when you look at those. So significantly less mucositis when treating these high dose rates. So this was just some of the work we did in mice. We also looked at osteoradionecrosis in the jaw. We looked at bone. We looked at all kinds of things with this, and we found the same stuff going forward. I will mention there was also a trial with electrons that was going on at the same time, where the group in Switzerland and in the UK also were treating cats with high-dose electrons for oral tumors. There were a couple issues with that. One, they could only get the veterinarians 1 day a week, so they gave the whole dose in a single session, and they were giving over 30 gray in a single session to the cats. And they had a number of cats develop osteoradionecrosis. Going to the fact, if you give too high a dose, you can overwhelm the flash effect. That's exactly what they saw. So to me, it wasn't a surprise at all. So their next study is now fractionated a couple times as opposed to the entire course in one treatment. Oops, sorry. So next, we went into head and neck cancer in dogs. Again, I didn't know this. Dogs get naturally occurring head and neck cancer. They get melanomas a lot. They get squamous cell carcinomas. So it turns out we could actually treat them. And this was called a 3x3 dose escalation trial. And what we were doing 2 fractions. And we started with 8 gray shoot through. So that technique where we use the plateau phase all the way through the animal. Then we did 12 gray per fraction shoot through. And then we had been working on conformal flash. We had to develop the treatment planning system. There was no treatment planning system to do it. So we worked with IBA and RayStation and we have a research agreement with RayStation where we developed a treatment planning system for this. And we were able to move into conformal flash where we used the Bragg peak and stopped it. So there's no dose beyond that, which was really interesting. And we treated, this was the first conformal flash treatment. So we completed this trial and the dogs actually did pretty well. In fact, if you look over on the right, the bottom graph were the initial dogs. And if you look the first series, all the dogs died at a certain number. But we didn't see significant toxicities in the flash group, which was great to see. Interestingly, if we look at the dogs in the conformal flash group, we actually have, this isn't updated yet, I have one dog out over 18 months with no evidence of disease and no issue at all. Another one who died of natural causes unrelated to this at a year and a half. So we've got two of the conformal flash dogs that have gone way out more than expected. So we had outstanding results. The FDA in the United States was actually waiting for these results. And we actually, to move forward with our clinical trial, we've been working with them very closely. This is my team actually treating at about 2 o'clock in the morning because that's when we get access to the beam. We're treating with patients all day and into the evening. So this is our last dog patient that was treated actually about a year ago now with our team. Very happy to get the last one done because this was not, doing general anesthesia on dogs in a different building in a human setting is not easy. And my team did a fantastic job with this, but you can see the brass aperture in place there and the nozzle and the system for spreading out the bag peak. And yeah, we even made those custom-made 3D printed things were made for the dogs too. So the whole flow we did with the dogs that we will do for humans. And then we also embarked on a number of studies looking at our current patients and looking what we did. And we were treating with VMAT or protons on most of our patients, but we took this research system and put it to work. And we came up with plans of left is VMAT, all the way right is a current clinical proton plan, and in the middle is conformal flash. And I'll argue the plan itself looks pretty damn close to conventional protons, doesn't it? So there's no exit dose. So normally if we did the shoot through technique like they're doing at Cincinnati, we would go right through the mouth, right through all those taste buds, everything. We're completely sparing that. So I know this patient would not get any taste bud issues. This patient's not going to have mucositis in most of the mouth because we're not even hitting it. So you can see the difference there. So I'm very pleased. That's a part of our FDA submission is the research RayStation treatment planning, which is the first in the world to be able to do this. And this just looks at a flash proton plan on the left, the VMAT plan again on the right. Again, you can see how the low dose is cut off where it's spread out throughout the tongue and the opposite side. We just don't see that with flash. We can stop the dose in a single treatment, but get the same conformality is which importantly with the VMAT plan. And this is the 15 gray dose level of doing this. So what are our plans going forward for human trials at Flash? Sorry, going too fast. The Flash kit is installed. You saw we've been using it for canine patients, and we're still using it for canine patients every day. Not every day, every time we have a canine dog in there. IBA is sponsoring the first human Flash clinical trial with us, so we're working very closely with them. We're working very closely with IBA and the Food and Drug Administration in the US to get approval to use the system. Our third, what we call pre-submission, was 3 weeks ago with the FDA. And I actually just heard yesterday, the day before, we had a very good call with the FDA to go our final submission, which we hope is in about 2 months. We're still working through that, but we're hoping to put the final submission for approval. And then we're hoping to actually start human clinical trials with Flash in the spring of 2026. So this is real. This is coming. We're going to start human clinical trials, which if you think about, it's kind of a rocket ship to go from a thought, could we do this 7 years ago, to human clinical trials is really super fast. So I'm thrilled with where we've gone, where we've worked through animal studies, and where this is coming up for the future. And it's, so far, Flash has met all the criteria you want to get through to human trials. And we've seen it in varying ways. So what are we planning? Our first clinical trial is a phase 1 feasibility study in head and neck cancer. We are going to treat patients with unresectable, recurrent, previously irradiated patients. So these patients have no other options. They do not have curable disease otherwise. They've gotten previous radiation. We have a lot of experience with giving reirradiation, and the head and neck is very difficult in those patients to do that. We know what the data are. There's actually very good data from the NRG in the US where they did a clinical trial doing SBRT of Acre times 5 to recurrent head and neck cancers. And there's good data out there. So we are actually going to be using a regimen of Acre times 5 in this. And what's the primary endpoint? It's feasibility. Can we deliver the doses we want? And I want to remind you, everybody forgets this. The tumor response is the same, whether you're at flash dose or at standard dose. So when you plan for this, you're kind of doing the opposite of your thought process. I don't care if the flash dose is in the tumor or not. I want the flash dose in the normal tissues. So I'm trying to distribute that dose of flash evenly in the normal tissues. The tumor, I don't care. It doesn't matter. I just got to get the total dose in the tumor. I don't have to get it doesn't have to be flash dose rate. So that's very different from when we think about treatment planning today and how we optimize things. So it is a different way to treatment plan going forward. And so it's Acre times 5 for the reason I mentioned already, is in our discussions with the FDA, they were very wary about us going to too high a dose per fraction, and they want us to use a regimen that was already published in the literature. And there's very good data on Acre times 5. We can compare to that and make sure we're not having way unexpected side effects on this. So that's the rationale in negotiation with the FDA, why we're doing that dose rate. We're also being very careful on the patients we select. Obviously, it's going to be smaller sized tumors that you could treat with SBRT. We're not going to treat tumors that involve the carotid artery. You worry about a carotid blowout and things like this when you're giving reirradiation. So we're being very careful of who we select in this trial. So I mentioned at the beginning of this talk that I thought flash could be a disruptor in oncology. And why do I say that? So it certainly has the potential to really compress radiation treatments. And radiation could be more like a surgical procedure that people travel to, as opposed to many weeks of treatment. It could be 1 to 5 days of treatment. It certainly could improve the quality of life of our patients getting treatment with reduced toxicity and a lot less time commitment coming in. As I said earlier, it brings together biology and technology in really new ways. And I'm very excited about where this can go. I think we have to stop thinking about just technology. It's how this all comes together for the future. And although our first studies are in flash, believe me, we're working on how do we combine with other stuff? How do we manipulate the immune system? And as I said already, we already know that we're seeing different immune infiltrates. So we know, and we're seeing different gene expression profiles. I didn't show that today from flash. So again, also opportunities to use drugs in combination with radiation that we've never been able to before, or develop new agents that we haven't been able to use before. I mentioned already about benign diseases of the heart being one we're working on, but there are plenty of benign diseases that act malignant, that impact people's lives. And if we gave less toxicity with the radiation we do, having a potential outcome, that's a benefit. We certainly see it has a potential to reduce the cost of radiation and at the same time be financially successful. We have something called alternative payment models in the US, so where we get a single price for everything, which is similar to what you have here. And I think that will allow us to choose what's the best therapy for that patient, can we reduce the cost, things like that. So I think there's opportunities there. The other thing I should say, that I didn't get into is from a mechanism standpoint. We have very much focused in on the stem cells and stem cell compartment, as I mentioned earlier. And why do I say that? Well, we are seeing that stem cells, in any organ we look at, 2 things happen. One, the stem cells are preserved. So when we treat with standard radiation, we see the stem cells wiped out. I'm sorry I didn't put a slide on this. The stem cells are wiped out. When we treat with flash, many of the stem cells remain and are not wiped out. But the second piece of that is not only are they not wiped out, they're actually stimulated into accelerated repopulation. So they heal. They heal really fast. They heal tissues really fast. And you ask, well, why does that happen in a tumor, or not in a tumor, it happens in normal tissues? Well, we think there's a couple, it's homing in, it's probably multifactorial. And many people want that one silver bullet answer, here's why. It's not that. We're finding there's an oxygen effect here. We know tumors are more hypoxic than normal tissues. And by having hypoxia, they might not have this protection of the stem cells in some ways, where we're seeing the protection in the flash environment. In fact, if we retreat a tumor, we don't do it day after day. We actually have days in this trial, multiple days in between, because it turns out if we treat a tumor the same day with another fraction or the next day, we don't see the flash effect. We think it has to do with this oxygenation issue going in there to the normal tissues. And two, there's a lipid peroxidation issue. There's something going on with fatty acids and lipid peroxidation of the normal tissues that impacts the way they heal and respond to normal tissues. And there's some other things out there that we're looking at, but lipid peroxidation and oxidation are absolutely coming to the forefront, and this protection of stem cells or tumor microenvironment in the stem cell compartment is altered for what we see with conventional fractionation. So in summary, protons, I already showed you, I'm already excited about protons. This is like going from Star Wars to next generation stuff with Flash, right? This is really jumping ahead Star Wars many years. I think there's amazing opportunities to combine with biologics, immunotherapy, chemotherapy. I think Flash has the opportunity to upend a lot of our assumptions. I'm rethinking radiobiology as I learned it as a radiation oncologist. We need to do it through rigorous science. We're doing it very, very systematically, as you can see at Penn. We've taken it large animal studies, I think was incredibly important before moving on to humans. We are ready to move on to humans. Clinical trials and cooperation across centers are going to be critical for this. No one center is going to be able to do all this. This is going to have to be a partnership with anyone who's involved in protons down the road. And this is a decade at least worth of work, at least, probably more. And I think there's going to be a lot of challenges. There's going to be technical challenges, biologic challenges, financial challenges to make this all come to reality. But I'm a total believer that with cooperation with people out here, as you get protons down the road, how we can coordinate with you and your ideas to drive this forward will be critical. This is my team working on this. I'm very fortunate to have, I get to talk about it. They do all the work. I find the money to do it. I find how to put the resources in, but they're the ones at 2 o'clock in the morning doing this stuff. We do have collaborations with Heidelberg and the Carbon Center there. We have collaborations with Princess Margaret, also with Oxford University, where they're working a lot with electrons with us. So it's a pretty large set of partners that are doing this, and it's just continuing to grow. So thank you very much.